Kia ora koutou, welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners. My name is Dr. Helen Carr, I'm a GP, and today we are joined by Professor Angela Ballantyne to discuss some commonly encountered medical ethics cases in general practice. Professor Angela Ballantyne teaches bioethics within the medical program at the University of Otago, Wellington, and has held roles with the World Health Organization in Geneva, Yale University, and the National University of Singapore. She has served as president of the International Association of Bioethics, was a founding member of the International Journal of Feminist Approaches to Bioethics and advocacy group Birth Trauma Aotearoa, and contributes to national expert groups on AI, research ethics, reproductive ethics, and immunisation policy. Welcome, and thank you very much for being here, Angela.
Kia ora, thank you so much for the invitation.
I thought we could just dive straight into some hopefully pretty commonly encountered clinical scenarios.
Great.
And just have a chat about the ethical components of each of the scenarios.
Super.
So a patient asks you to prescribe a particular medication and you know that the evidence for it is pretty poor, but you think that they might benefit from a placebo effect, which would be reduced by telling them that the evidence was poor. How would you approach this scenario?
Super interesting. I say to the med students that most often the clashes that come up in clinical practice are when you have a tension between autonomy on the one hand and beneficence on the other hand. And this is a really good example of that, because the reason you want to use the medication is because you think the placebo effect is going to be of some sort of therapeutic benefit for the patient. And on the other hand, you've got concerns about honesty and disclosure, and those relate to autonomy. So autonomy is about patients' capacity to be self-determining and to lead their own lives and, in this case, direct their own health pathway. And the reason we worry about disclosure, access to information, and informed consent is because that's necessary to support autonomy. And then in the background, you've got an issue around kind of public trust and honesty. So again, you're sort of weighing up what might be beneficial in relation to this individual incident versus what impact that might have more broadly if doctors start prescribing placebos commonly in a way that's not supported, and would that then diminish public trust generally in providers and threaten that sort of therapeutic relationship, which is the underpinning of good medical practice. So those are kind of the ethical issues that are top of mind. I think there's really interesting semi-recent research on open label or non-deceptive placebos. So in the way the question's framed, there's a tension between you want to benefit the patient on the one hand, but you don't want to be fully honest or open with them. There's some research which is really fascinating that in cases where you tell a patient it's a placebo and that there's unclear evidence regarding why it works, or it's likely only to work because the patient believes it works, you still get that placebo effect. And this has been in cases from irritable bowel syndrome, ADHD, depression, chronic low back pain, and even a study in relation to fatigue related to cancer treatment. And that in itself is really interesting, because I think it raises the question about how much patients understand in relation to the normal informed consent process. So if we say to a patient, look, we don't know why this is going to work, or we think it's the action by which it works is a placebo. From our perspective as experts, that seems really different to saying, oh, there's this huge clinical evidence and there's all these studies and we know the pathway. But from a patient's perspective, maybe just a recommendation from the doctor is the bit that really matters. So I suppose that's a starting point.
So a bit of that question of if is omitting information equivalent to deception or lying, and is there different levels of that? Most patients I find aren't they don't pin you down or ask you specifically what the mechanism of action is for the medications that you suggest. And so I guess if they're not particularly hung up about that, how do you feel about not necessarily mentioning the way it might work?
Yeah, so legally the standard is set out in the HDC Code of Consumer Rights. I prefer to talk about patient rights, but legally they are consumers of health and disability services. And the patient has the right to be fully informed, but obviously that doesn't mean that you tell the patient absolutely everything. So the patient is entitled to information that a reasonable patient in that patient's circumstance would expect to receive. And that includes general information about the results of tests, the diagnosis, alternative options, treatments and potential risks and benefits. So long as you're working within that, I think that's reasonable medical practice. You're right that a lot of it can come down to the subtlety of how you present the information. So I think at base, you'd want to be asking, what are the patient's expectations and what kind of outcomes are really important for them, and understanding that. You'd want to be clear that there was weak or uncertain evidence as to why this would work. So you're being clear with them that this isn't an area where there's a huge amount of evidence, and that's why you're using it off-label. Or you can say that you are unclear about the mechanism as to why it would work, and in your expectation as a clinician, some of your assessment is based on placebo evidence that if patients believe a placebo works or believe a pill is going to have an effect, that does actually have a therapeutic benefit, even though we're not quite sure how or why that works. You then want to talk about what the alternatives might be. So if the patient has requested this particular medication, you're responding to that, but you might also want to give them options of saying, hey, there's these other alternatives and these are more evidence-based, or here's the evidence for those. And then I think you'd want to focus on monitoring. So making sure that you are following up with the patient about their experience and whether they are experiencing any side effects and whether they're achieving the therapeutic or clinical benefit that you both hoped for.
And were there any factors within that research that are other things associated with increased response to the placebo?
This is a slightly tangential answer to that, but there's an interesting study in New Zealand of patients. This was in 2009, so a little while ago, but Chen and Johnson did a study of patients receiving care through general practices regarding their acceptance of placebo use. And a couple of findings. One is most of those patients were surprisingly happy with the idea that doctors would prescribe placebos, so long as they thought there was a prospect of clinical benefit, particularly if the patient had requested it and if the risk was low. But what they did find in that study was that patients in the study had quite poor understanding of placebo effect and how it worked. And in particular, they thought that the placebo effect relied on the personality of the person, or the kind of particulars of the person receiving that placebo, as opposed to being a more standardized response across a population. So I don't know if there's any specific research regarding who's more likely to respond to placebo effect. That's not something I'm aware of off the top of my head. I think, again, part of what's interesting and sitting behind this question is that biomedical distinction between the brain and the body. And so quite a sort of traditional approach to medicine is that there's a big difference between physically what the body does and our mental and psychological states. And I think that's being challenged, more and more in relation to recent research and ways of thinking about that interaction between the two. And so placebos kind of sit in that space, that it seems on one level to our very sort of rational brains implausible that just believing something can actually result in less pain or fewer ADHD symptoms. But perhaps the connection between the brain and the body is more subtle and connected than the biomedical model leads us to believe.
Yeah, because it does mean we do give lower value to the response of a placebo. But you're right, what if it's just the mechanism through which it's therapeutic? Because why is it less valid than other forms of medicine?
And that question is do we understand why, or do we just care that it works, is not just in here. I mean, that's a really key question that's being raised in relation to AI at the moment, right? So you've got the whole black box issue in relation to AI apps in medicine. And there's quite a really active debate around, do we just want AI that works? And we know that it works because we test it in clinical context and we find it's more accurate than human decision makers. Or do we only trust AI where we have some idea of what's going on behind it? And there's an inverse correlation between how complex the AI is, so our limited ability to understand it, and how accurate it is. So that's a kind of really clear trade-off in another area of medicine.
And as a profession who prides ourselves on knowing in this very empirical way, is there a consensus as to, well, I guess this is the whole thing about how doctors are, how we're given the sort of power or the authority to make decisions and knowledge, because our knowledge is seen as sort of more predictive or more complete.
Yeah, look, and that I think spins out into so many different areas in terms of unconscious bias and sort of epistemic authority and the knowledge that and expertise you have as doctors and your ability to, you've got clinical experience and you've got the ability to read evidence versus a patient's knowledge which comes from experiencing the condition subjectively and authentically in their own body, and how you navigate those two forms of knowledge in a kind of patient-centered care an evidence-based approach to care.
So following on from that, similar principles but slightly different angle, if we're really hoping that someone would start a medication that we think they'll really benefit from, like a high-dose statin or something, and there are some low-frequency, low-risk side effects that you think mentioning to the patient would really put them off, what would be your approach to this conversation? And is it essential that we do mention, I mean, there's a whole list of different side effects. How do we sort of choose the ones that we mention?
Yeah, that's such a great question, and a really practical question in terms of the fact that a number of disputes or cases where there's a critique of clinical care do come down to this question of disclosure. So Marie Bismarck, who's a psychiatrist and public health expert who works in New Zealand and Australia, did a review of legal disputes in 2012 in Australia, and there was nearly 500 disputes that were about informed consent, and almost 10% of those were about disclosure. So did the doctor tell the patient the right kind of information before the patient made a choice? And the background to that, I suppose, is also just recognising that in the HDC Code of Patient Rights, patients have the right to decline medically indicated treatment. So as a doctor, you're always motivated by clinical benefit and wanting to ensure the patient gets the best treatment and the most appropriate and evidence-based treatment in order to maximise their clinical outcomes. But patients do have the legal right to say, no, I don't want. I don't want to do what's sensible or evidence-based. I want to make a different choice. That doesn't necessarily help you in terms of which specific information to give the patient. So, as I said earlier, the legal standard is you need to disclose what a reasonable person in that person's circumstance would want to know. And this is enacted in the HDC Code of Patient Rights, Right 6. And that comes from two legal cases. One was from 1972 called Canterbury and Spence. And that was a case where a 19-year-old had surgery on his spine and became a paraplegic and incontinent after that. And the legal case looked at whether the physician had provided the right type of information. And that was really the case which shifted from a physician or doctor-centered standard of disclosure to a patient-centered standard of disclosure. So prior to that, this was a US case, the standard had been so long as the doctor says what an average doctor or a typical doctor would say in this context, that's sufficient. And that shifted to no, actually, it's the patient who's experiencing the harms of the procedure and the benefit. So it needs to be patient-centered, not doctor-centered. And so we got that idea about what would a patient expect to know. And a more recent case in 1992, which was an Australian case, Rogers versus Whitaker, looked at what are material risks. So material risks are any risks which would be material to the decision, meaning like actually influence the decision, as opposed to just being interesting facts that wouldn't have influenced the patient's decision. In this case, Miss Whitaker was having an operation on one of her eyes, and she had expressed concern that the operation wouldn't impact the sight in her other eye. And there was a 1 in 14,000 risk that her sight would be affected. Now, essentially, she became blind due to a symptom process I'm not familiar with, but called sympathetic ophthalmia, I think. But the result was that she couldn't see. And again, even though the risk was only 1 in 14,000, in that case, the judge determined that the doctor had failed in their duty to disclose because she had expressed concern about that eye. So I guess what this comes down to is the better you know your patient, the better you're able to meet that legal standard. And so if your patient's a pianist and there's a very rare risk of hand injury, that's probably really relevant to that patient in a way that it's not to someone else. So the reasonable patient standard really says, get to know your patient. If you think that that side effect would be material to the individual patient in front of you, you have a duty to disclose, even if you think it means they're less likely to take the medication you think is useful. Or if you think actually a reasonable patient in this patient's circumstance, like with this sort of job or at this age or with these kind of interests, then you should disclose as well.
That's really good to know. So just slightly change of topic now. If you notice one of your patients reminds you of someone that you like, or conversely, someone that kind of gets under your skin a little bit, you're either putting more time into one of your patients' care and then maybe trying to get someone out of the room quicker. Could you talk us through what's kind of happening here and what the ethics of this is?
Yeah, that is, again, such a good question. So I think there's two things that happen. I mean, one is on a personal level. You might, yes, you say it might remind you of someone that you don't like or someone that gets under your skin. But even if you don't have that personal reaction, we all judge people who we're interacting with based on their physical bodies. And that is everything from like attractiveness to height to weight to how they're presenting. So their gender presentation, what we take as a read of their ethnicity or racial category. And the literature on unconscious bias suggests that that has a reasonably significant impact on how we choose to interact with that person, which I suppose comes back to that idea around, are we sort of rational, objective decision makers, or is there stuff going on in our head that we're not even aware of? So that's relating to that AI conversation. On one level, we say, well, we would only trust AI if we knew how it worked. But I suppose my response to that is, well, we only have limited understanding of how our own brains work, right? So one example of that is in relation to height in politics. So there's quite an established pattern that taller candidates are more successful. So if you take the average height of US presidents, it's about 5 centimeters taller than the average height of men in the US population over that time. So height's a definite advantage because we associate height with authority and power. But if you said to someone, why did you vote for that candidate? They'll say, well, I liked their policies, or I thought they were trustworthy, or I really didn't like the thing they said about that. Very few are going to list, oh, well, I looked at their height and they were taller. So there's a bunch of stuff that influences our reasoning and our judgment, and that's as clinicians as well. So my response to that is dual, which is that part of what makes medicine effective is a human connection. People need to feel cared for, and there's a healing aspect to the therapeutic relationship. And to come back, I suppose, to things like placebos, even if you've got a 1-hour consultation with a naturopath or a homeopath, and they're giving you medication that we don't have evidence to suggest, has a scientific mechanism that we understand, the prospect of being listened to for an hour is often healing for the patient. And so no one wants a doctor who's what's the word?
Automaton.
Yeah, there you go. And you're not going to enjoy your job if you don't connect with patients, right? So on one level, accept that you're never going to interact with every patient in the same way. On the other hand, I think it's useful to be aware of some of the evidence around patients who receive lower quality care and less rapport, and for doctors to try and take that into account when dealing with those patient groups.
Makes me think a bit about telehealth and how, on the one hand, you mentioned how important it is that we have longer term relationships and know our patients so well. But then on the other hand, things like telehealth can actually probably remove quite a lot of those unconscious bias processes.
Yeah. And then again, to come back to AI, right? Well, there's bias in AI, but it's a sort of standardized bias, I suppose, as opposed to, it probably irons out perhaps individual level clinicians' bias. But as we move to things like precision medicine, where we're using genomics to try and influence delivery of care, so more targeted delivery of care to stratified populations, and AI-driven algorithms and telemedicine, it's this quite algorithmic approach to medicine, which on one level is supposed to take a whole lot of evidence and digest that and apply it to the patient in front of you. So it's likely to be quite accurate. But at the same time, it misses out that sort of patient-centered, humanistic tailoring of the clinical recommendations to the patient based on your knowledge of their values and your relationship with them. So I think over the next sort of 20 years, that's going to be a really interesting tension to see play out.
Yeah. So lifestyle interventions and obesity and the ethics of weight loss medications and things. Just thinking about, if a patient comes to you, we know that the evidence for lifestyle interventions for sustained long-term weight loss is poor. And now that we have a raft of medications with pretty good evidence, it feels like that's sort of the more tempting thing to offer. But if someone comes to you and they're newly motivated about their lifestyle changes, maybe they're hoping their new gym membership is going to lead to persistent benefits, and they ask you about this, how do you approach this conversation?
Yeah, that's been a real shift, hasn't it, in sort of the last 5 years? I think that recognition that diet and exercise-based interventions for sustained weight loss aren't very effective. And so we've seen a real shift, which is fantastic recognition of the limited evidence. So I think that is an area where assumptions and stereotypes and assumptions about the relationship between weight and health are really dominant. And unpacking that is actually really tricky in terms of the evidence, because I think those assumptions feed into how the studies are designed. So one of the issues is that a lot of the studies look at very intensive interventions with a lot of counselling support that then isn't maintained at the end of that intervention, and only look at short-term weight loss for between 6 to 18 months. Whereas we know that there's what's sometimes referred to as the near ubiquitous weight regain journey. Over 2 to 5 years, most people regain that weight and often more weight. So they're in a larger body subsequently. So I think if someone comes in and asks about that, and this links back to what we were saying earlier, the best thing to do is to explain the evidence as you see it. So I guess I would encourage people to say, there's not a lot of evidence that people who diet in order to lose weight make sustainable weight loss gains. And there's actually a risk that if you are changing your diet with the primary purpose of weight shifting or weight changing, that you will actually regain that weight in the future. And it's important that you're aware of that because that should influence the decisions. However, there's great evidence that exercising and changing your diet for health-related reasons can have a really big impact. So here's the advice I would give you around going to the gym. That's fantastic. 30 minutes exercise a week, is going to have really significant impacts in terms of your overall health and well-being, cognitive, processing, and various things. And changing your diet can also have a really significant impact on colon cancer and a range of other conditions. So it's about reframing it rather than being about weight loss to being about where we know the evidence is, which is that healthy diet and exercise are really, really good for people. Now, obviously, if the person's like, no, look, I really care about weight loss, I think that's fine for that to be part of the conversation. You've got to kind of meet the patient where they're at. But to the extent that you're offering advice, I would try and keep that in the evidence-based area, which is around diet and exercise.
Lots of GPs, I'm sure, are noticing the increasing rise of peer-led or social media-driven diagnosis.
Oh, yes.
And also, I guess, with that sort of generally sort of non-traditionally medically trained clinicians as well, doing more assessment and diagnosis, which then ultimately, I guess, takes some of the power out of doctors and takes us out of the equation a little bit. And so I find it hard to think about this and form a perspective on this with some objectivity, because I know that I have skin in the game and I've got this inherent conflict of interest when I'm thinking about this question. So wonder if you had any thoughts about how could I think about this and try and include more ideas and perspectives to try and get a more objective opinion.
So I think there's different groups of patients who are engaging in that peer-to-peer information or diagnostic journey. And I think perhaps in some areas it's more justified than in others. Some of the patient groups that I work with or sort of do research in relation to healthcare delivery for those populations are groups where there's quite a lot of evidence that over time they have been systematically underserved by medicine. So that would be fat patients, for example. So we talked about that question about rapport and like connection, and then also weight. Or lots of research with patients who are in larger bodies. And I'm happy to use I use the term fat sometimes in recognition of fat activist scholars who have reclaimed that term as an identity as opposed to a shaming. And actually there's, quite a bit of objection around the term obesity because it's pathologizing, and the term overweight because it suggests there's a normal healthy weight. So there's quite a bit of controversy around terminology. So I'm using fat, yes, in response to that sort of critical fat studies literature. So people in fat bodies, some research shows that, so there was a study in 2013 that showed that doctors spent less time building rapport with patients who were in larger bodies, and that's positive rapport, emotional or social rapport, and that's doing things like using humor, acknowledging how the patient feels, giving positive praise, or like, so this is a really difficult situation and you're doing really well. And from that, right through to research that shows that patients, so this is a study by Albergia in 2019, which was a scoping review of 21 studies, which found that fat patients experience medicine as demonstrating consistent contempt, being patronized, being disrespected, and a consistent misattribution of the patient's medical symptoms to weight. So patients coming in with a variety of symptoms and just being told to lose weight as a response. So misdiagnosis, poor diagnosis, and then because patients feel so stigmatized by doctors, fat patients, this leads to them delaying care or avoiding care or doctor shopping, which again has an impact on whether they get timely healthcare. So that's one population. Women with chronic pain is another patient population where, again, there's lots of research that historically the idea of kind of female hysteria in terms of attributing women's psychological or pain symptoms to women being more emotional and unreliable authorities on their own bodies has led to the undertreatment of women's pain. So one study found that women in hospital are more likely to be given sedatives than men when they express the same pain-related symptoms. Men are more likely to be given pain medication. Women are more likely to be diagnosed with depression when they come in with pain symptoms. So there's sort of certain, and I suppose endometriosis and menopause would be two other groups of patients who have struggled to, in their view, get sufficient medical recognition of their symptoms. So again, a minimization of period pain is normal. So I think the response in those contexts is to be aware as a medical provider that the patient that is coming to see you has probably experienced barriers to having their symptoms and lived experience recognized as valid, and has probably done some background research around who are the doctors to talk to regarding hormone replacement therapy and who are more dismissive and who are more helpful. And that can be really empowering for patients. So that's not always a bad thing. And I think if you can kind of meet patients where they're at and have some sensitivity to the fact that when they walk in to see you, they're carrying quite a lot of baggage, particularly for these communities. And it's not necessarily to do with what you do in that interaction. It's that you're trying to remedy and fix a degree of mistrust which has already been built up. So I think in those areas that peer-to-peer information sharing can actually be quite useful and a reasonable challenge to medicine. I suppose there's other areas which you probably see more of and I see less of, where it's kind of really unhelpful and patients are coming in, convinced they've got stuff that they don't have or wanting medications. I mean, the other thing in New Zealand in terms of context is that New Zealand and the US are the only places that allow direct-to-consumer advertising of medical products, which provides a context whereby, pharmaceutical companies can manipulate patient groups or patients to see certain medical conditions they wouldn't otherwise have recognised and to come in requesting medication that may not be appropriate or necessary. So that's a bit of background context as well. Now, I can see that it's a challenge. I guess for the individual clinician, I would say practicing recognising the limits of your own knowledge and that's different in different areas, right? So the limits of your knowledge in relation and the biases you'll be experiencing in relation to fat patients, given there's so much upheaval and reinterpretation of that evidence at the moment, will perhaps be different from something, I don't know, where it's more standard, like diagnosing breast cancer. And then also realizing and being aware of your own emotional reaction and how that's completely normal to feel frustrated and threatened by that. And then once you've acknowledged that, trying to set that aside and then really working on building like a trusting therapeutic relationship with the person in front of you and acknowledging maybe the frustrations that they're bringing to the table.
Yeah. What would be your advice for GPs or nurse practitioners who are keen to learn more about medical ethics and to get some more skills in this area?
Oh, great question. There's lots of content on YouTube now and there's lots of webinars. So one thing that's, even for me, because I often feel like in New Zealand I'm a little bit removed from my prior academic colleagues, lots of lectures are recorded online and there's a number of academics who do short sort of 10-minute videos and chats. You can look for webinars on patients who have experienced birth trauma and their experience in trying to engage with the medical system. There's great podcasts, some really good podcasts around weight bias, health at any size, sort of fat positivity content. Interesting podcasts. What is it called? It's a spin-off of This American Life. And there's two. One, and it's about women experiencing pain and being undertreated. The retentionists, maybe. And one is in relation to undertreatment of women's pain during egg retrieval processes. And the other, which has just come out, season 2, is about women's pain in relation to cesareans. So 100,000 women every year in the United States have their experience of pain, so the anaesthetic isn't working during a cesarean, ignored or dismissed by health providers. So quite remarkable. So I think there's lots of content out there, and this is everything from sort of a 10-minute clip you can watch on YouTube if you're really quick, if you're really busy. Obviously, there's an issue around quality sometimes, but in particular, if you know there's, if you recognise the university So if it's a university podcast or an academic lecturer, usually they'll be pretty accurate. The one thing I would say is sometimes if they're talking about law, that might be law that applies, say, in the UK or in Sweden, but not necessarily in New Zealand. And I mean, if you're more interested, the Bioethics Centre in Dunedin at the University of Otago does a master's in bioethics. And so that's how I got into this area, because my background was in science and genetics. And I wasn't quite sure what to do after that. So I went to Melbourne and did a 1 year, like a sort of a baby master's in bioethics. And it was the most amazing class because it had people that had come through from philosophy, a couple of us that had come through a science degree, and then a number of experienced clinicians and nurses. And the sort of multi-dimensional interdisciplinary conversation around these complex issues was just so fascinating. I was hooked.
And just finally, what would be your key take-home messages for our listeners based on today's discussion?
Yeah, so great. And I think one thing that kind of runs through a lot of the questions is this, which I haven't mentioned this term, but the idea of epistemic humility. So that just means having some humility regarding the limits of your own knowledge. And so that relates to issues like unconscious bias, that often there's stuff going on in our head that we're not even necessarily aware of, and that it would be hard for us to identify other than in population level studies. There'll be issues to do with rapport and how you personally interact with patients that, again, you might not be aware of. There'll be limits to your knowledge as a health provider that certain patient groups will be pushing back and challenging, and that's a really healthy process in rebalancing. And those questions around AI as well, like what do we need to know? And what forms of knowledge are most helpful? Do we care that it's accurate, or do we care that we understand the mechanism? So I think that's hard for a doctor, because a lot of what you're told is, you matter because you are the gatekeepers of this medical knowledge. So practicing that epistemic humility around being reflective about what are the limits of my knowledge and where am I really confident that my knowledge is strong and well balanced can be challenging, but I think is really important for dealing with these issues. Yeah.
Thank you for that rich conversation. I think, given me a lot to think about.
Thank you so much for having me. That was great. And great questions.
If you're a New Zealand GP and would like to claim CPD points for listening to this episode, our podcasts are eligible, so please log them. We'll post any links to relevant resources that we've discussed in this episode on our website at goodfellowunit.org. And if you'd like to get in touch, we do value your feedback, so you can email podcast@goodfellowunit.org. Thank you for listening.